I want to thank Dr. Lowell Kabnick and Dr. Fedor Lurie to agree to give us this talk on the 20th anniversary for the EVOLVE study. This is the first randomized controlled study that really helped establish endovenous procedures worldwide. This particular study randomized patients between endovenous radiofrequency ablation, the closure procedure, versus ligation and stripping. Both of these speakers are leaders in the venous field and worldwide experts in this technology. So can you just mention, Dr. Kabnick, how did the EVOLVE study get started?
So we were looking actually to compare stripping, the open method, to the endovenous method, better known as closure at the time. And it was really kind of new. It started as far back in 1999. There was a trial before that in 1998, but that was submitted to the FDA, and the FDA then approved it with the trials that occurred, which was basically outside the United States with that. And then a group of us got together, and Fedor Lurie was there as well, people from outside the United States, and Rob Kistner from the US. And we put together the EVOLVES trial. But before that, it was really kind of not covered by insurance companies, and patients had to pay out of pocket for it. But just the skinny of it, and Peter will probably go into the methodology and the results. What was interesting for me was here I had already almost converted my practice to endovenous at that time. And patients were certainly lining up at the office to have it done, but an informed consent was given. You could have this or you could have that. These are what can happen to you, and yada, yada, yada. And the amazing thing is when the trial came, you had to randomize your patients to stripping or endovenous. And I had a hard time enrolling patients because they didn't want to go through stripping anymore. They had heard either me or another bunch of my colleagues talking about it, and or some of the marketing from the company, and there was no question which one they wanted. Matter of fact, one or two of my patients who were randomized to stripping dropped out. So it's like, okay. So, but I already knew that I was convinced that this procedure was going to take off. And remember, we're dealing with generation one, and now there are at least 4 generations of RF. So this was a different type of procedure than we do now. And it was a percutaneous procedure, or some people resorted to open. You know, they'd make a little nick and they'd bring up the vein and then canalize the great saphenous vein that way. And then on top of that, some people did it under general, some people did it under epidural. But the real key here was to do it under tumescent. And tumescent was just coming in to vogue at that time. And it was borrowed from liposuction. So to make a long story short, the pullback method and the wrapping of the leg was significantly different than it is now. So we used an Esmark bandage to decrease the amount of blood that was in the vein, because radiofrequency works by contact. It's really conduction. And so you really didn't need to have contact. Plus the catheters were different. We had 2 different catheters. They worked differently, and the pullbacks were different. So I remember it's a continuous pullback, and help me out here, Fedor, you could chime in, but it was 1 centimeter a minute for the first 5 centimeters, and then 2 to 3 centimeters thereafter. So the procedure was very long, but you know, the patients post-op, it was amazing. You know, when we first started stripping, patients were in bed for a week in the hospital, and these patients were getting discharged. So when I was at Mount Sinai, there was a gentleman that was doing stripping, Robert Nabatoff, who essentially did strippings of a patient and sent them home. When I went to Morristown, they were keeping patients in for 3 days, and I begged my partner at the time, can we take the stripping patients and let them out at a day? And he finally acquiesced. But this one was amazing. You could see the recovery, and it was amazing. So Fedor, I'm going to stop because you have a lot to add to this and the trial, and you were really the PI of it. So I'm going to turn it over to you. But I may chime in.
Well, thanks, Lowell. I think you nicely describe, well, what you really nicely describe is a challenge and the reason why the trial was finally stopped before we enroll the patient that we needed to enroll, because just was impossible to randomize patients. Like literally, it was really difficult from the beginning, and we were over a year in the trial, and it was obvious that we would not be able to complete the numbers that we aimed to do, and that's what is good. But let me start with a little bit of a background, which Lowell very nicely described from his practice at that time and the patient perception. But those of us who remember well 1999, when the radio frequency was approved by FDA, yes, there were 3 or 4 practices in the United States that adopted it rapidly. You're talking about 3 or 4 out of many. And the resistance to this was absolutely astonishing. I mean, you cannot really talk at the meeting at this time that you do radio frequency in the office, or you're going to be killed. It's unethical. You cannot risk patients' life doing procedures in the office. Oh, you discharge them right after the procedure? Are you crazy? You cannot imagine how much of resistance it was. And that was actually the reason for trial, because the device was approved by that time. The company didn't need the trial for approval. They didn't need it for reimbursement. Well, yes and no. Lowell can do definitely say more about this. And what also Lowell very nicely touched upon is a patient perspective, and that was that was a big discussion. What would be the primary outcomes? And that was the first trial in the venous space with the quality of life as a primary outcome, which was not recognized by FDA by that time. So it was blessing that FDA was already approved. We don't need to do it. Was not recognized by professionals and societies as the primary outcome. And so that was a challenge. Then there was another one, and that's interesting because Lowell said it, some negative sequel of the trial. So the size of the vein, the reason why we limited by 1.2 12 millimeters vein was the size of the catheter this time. So it has nothing to do with the efficiency of the technology. And that's, I think, FDA approval was also because of the size. And then all the sequence was like, well, you cannot treat the veins that are more than 12 millimeters for years. And that was not, the technology changed by the time, and the lasers were already in, and still it was a limitation. So it's amazing how people take just surface, the study and go forward. So anyway, so Neil, you would ask questions because we.
So I can just elaborate on one other point. So a 12-month study I presented at the American Venus Forum, and I was hung out to dry. I mean, it was just like blasphemy. I don't know what I did wrong. I presented the data, The data was the data. It was really good data. It was certainly scrutinized by all of us, in the academic world, and just people from different universities. It was akin to when we switched from open gallbladder operations to laparoscopic. How can you do this? It's only two-dimensional. You're going to get into trouble. You're going to burn the blah 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 blah. It was like, it was amazing. It was just simply amazing.
No.
And Neil, I'll turn it back to you.
Oh, you say that there were quite a few challenges, not only with the study itself, but after you presented the study, people really didn't take to the study very well. They didn't sound like they believed it. They didn't trust the technology. How did you overcome some of this? Because laser was also starting to develop at the same time. It sounded like there was some competition going on between the two, also between not only the two technologies, but also between the two companies.
Yeah.
It was ugly. That's all I can say. It was really ugly. So it was interesting looking back and looking at the different technologies and understanding the early laser. It was a piece of equipment that did the same thing in terms of closing veins. The difference was that this was the early portion where we used hemoglobin-based lasers and a bare tip fiber. And so when the trial was, there was another trial that compared RF to laser using the older technology, and it was far superior with RF in terms of a lot of quality of life studies. But it was what it was at that time, and now, as far as I'm concerned, they're both equal, and it's fielder's choice on that. But just to go a little bit further, so people didn't really adopt this procedure until Medicare decided that they were going to approve it. And once they started to approve it and the reimbursement that they saw, it also helped them jump on and look at it. And they were losing patients. They were losing patients to Fedor. They were losing patients to me because word spread very quickly amongst patients. And you have a happy patient, they're going to tell at least three. So that was really the telltale sign of when things changed.
Yeah, and that's exactly right. And you know what? Coming back to the trial is, the secondary outcomes of the trial was return to physical activity and return to work. Now, return to work was a little bit tricky because, people may choose not to return on the first day, but return to activity was, although subjective, again, patient-reported outcome, not very much accepted at this time, but the difference was amazing. I mean, nobody argued that for stripping, patients did not return to normal activity for days. Everybody knew that. What people were questioning is whether patients really returned to normal activity the same or the next day after radio frequency ablation. But again, we had at some point, and Lowell mentioned it before recording started, two of us went to San Jose, California, where Venus Company was at this time. And we sat there for, I believe, for a couple of days, going through every single patient record and trying to sort out any questionable data points that could have been questioned. So that was quite excruciating exercise, but I think we did it just because we knew how much of resistance going to be at that time. Yeah, well, you probably remember that very well.
I do. And so just to look at where we've come from the EVOLVES trial in Gen 1 to where we are now, and that it definitely in the US is certainly the state of standard. It's a standard of care to do endovenous ablation. And it still remains, thermal ablation still remains the gold standard at this point. We have other modalities that we can also use, but still a lot of us prefer. And if I remember looking at some statistics, now there are 1 million endovenous procedures done in the US and 800,000 are thermal. Now that could change, but and there are new devices that are trying to be trialed, but still, where we've come from is amazing. And as you alluded to, there were some really ugly fights between the two companies, the laser company and the laser company. There were a couple of laser companies, and one sued another one for patent infringement. And then Venus Medical sued all of them for patent infringement. And instead of playing in the like nice people in a sandbox, it got really ugly. And it really kind of set us back a little bit in terms of, the way we looked at things, the way we analyzed methodology, because it just confused and clouded the issue.
So, but the impact is enormous, and people occasionally argue that patients are over-treated at this time. As Lowell mentioned this, but look, at time of the trial, 2000, 2003, every single patient that today is eligible for endovenous ablation would be considered for stripping. Every single one. I mean, if you have a varicose veins and you have reflux and great saphenous veins, those are indications of stripping. By the way, you don't have to be symptomatic at that time. So, that is how many patients would have been treated, but they were not, because it's a painful procedure. You have to stay in the hospital, all those kinds of things, and they are treated right now. So whether they over-treated or not, I really don't know, but I think it doesn't really make any sense to say that patients do not need to be treated.
So you touched a little bit upon the future. So where do you think the field will be going next with respect to the unmet needs for treating our patients with venous insufficiency?
And by future, you mean like 5 years or 20 years?
Let's just do 5 years first, because there are technologies that you said that are coming on board, and they are meeting some resistance, and some of them are collecting data, as you said, and a lot of them are having challenges, as you did 20 years ago.
So I can just hang in there for a little bit. The one challenge that we've faced, and maybe the standard of care is changing, and that is treating below the knee. We early on in endovenous, we knew that where the nerves were. We knew that if we went to the upper third of the calf, we would probably be out of harm's way for the saphenous nerve. And if we went to the gastrocs, we'd probably be out of harm's way for the sural nerve. And then the idea, as we had advanced venous disease came in, we needed to treat to the lowest point of reflux. So those with advanced venous disease, I'm talking C4, 5, and 6, we wanted to go as much as we could. Now, understand when we did stripping, there was, at first, we stripped from groin to ankle, and there was a lot of paresthesias or nerve issues with that. And then when we came to endothermal, it was a fraction of that. So we thought really good about it. And the C4, 5s, and 6s, they even have some paresthesias to begin with because they have skin changes. But with new technology and non-thermal technology, it seems that things have switched to other modalities. And one of them is Varithena, which is a proprietary foam. And so that does not seem to cause any issues regarding what we were concerning, paresthesias, et cetera. So now the question, and Fedor, I'm going to turn it back over to you. There seems to be a change in the standard of care. where there's an above knee great saphenous vein and a below knee great saphenous vein. As far as I knew, there was only one, but more than 50% of the people that are looking at something like this are treating in different modalities. And whether it's correct or whether it's because of legal reasons, it is the standard of care now. And I would like to hear your comment on that, Fedor, because it's something that I didn't practice, but it seems now that it makes sense to me from a litigious world that we're in. And if you evaluate your patient post-operatively, after you've performed a, in and around the knee ablation of the great saphenous vein, and the patients don't have any symptoms, you don't need to go any further. If the patient still has symptoms, then it's really up to you to discern if those symptoms are venous. And if they are, then I would personally treat. So maybe the percentage of patients that I'm looking at, it's not a 1-for-1, but it's less than a 1-for-1. What do you think, Fedor?
Well, I completely agree with that. I think the question, the really unsolved question, is which patients need to be treated above and below the knee at the same settings. But I completely agree. If you post-op, you have remaining symptoms and signs, they need to be treated. The other challenge is non-saphenous reflux, whether before or without reflux in the saphenous vein or after ablation. I mean, that is something that's really a challenge from reimbursement point of view and from CIT, but clearly those patients need to be treated. They have all the signs and symptoms the same or similar severity that patients with saphenous reflux have, but unfortunately as Lowell mentioned, non-thermal ablation, varicina or otherwise, I mean, any things may help there. But in terms of the future, I think one lesson that we learned right from the settings of the study was that the patient perspective is the key in venous disease. And so whatever technology you're gonna develop, the more patient-friendly it is, the more acceptable it's gonna be for the patients. And patients will see treatment regardless of what we think who should or should not be treated for a variety of reasons, lifestyle, cosmesis, whatever you name it. Patients will seek the treatment, and if there are options, patient-friendly options are available, that's going to be the future.
So we went from open to endovenous to thermal to non-thermal, and next we'll have a black box that's hovering above the patient, and somehow it will transmit to destroy the vein. But in reality, as Fedor remembers, this all started with the Restore catheter. And the Restore catheter was a thermal device to get the vein to shrink by shrinking the collagen so that the valves would coapt. And I remember hearing about this at a lunch meeting. And I said, wow. And it said they couldn't predict which ones would close and which ones they could restore to a normal vein in terms of flow dynamics. And that's when I went out and to Brian Farley, who was the CEO at the time, and I said, just close the vein. Because we were taking them out. We were doing these horrific procedures and stripping. Just close it. I would be perfectly happy. At that time, we were not using foam in terms of sclerotherapy. We were using liquid. And we know that if we used liquid, we get the vein to close, but 75% of them recatalyzed within 6 months. So we didn't have that. So that was another. So if we had a catheter or some device that could restore the hemodynamics, that would be much better than what we're doing in terms of destruction. So that's one of the ideas. As we go forward, it's kind of interesting about May Thurner. And May Thurner was a board question for us. how many May Turners did you see in training? And then all of a sudden it exploded. You know, we had technology that would help us. It really was trialed in Europe before it came over to us because of our FDA. They had a real head start with it. And then we started doing it in our country. But the number of cases that are just being done for May Thurner are overwhelming again. But it's still, it is a procedure. It is something that chosen the right patient at the right time for the right reason, you can have a good result. And then there are patients that have iliofemoral thrombosis, and that's a different story that recanalized. And those patients, to me, are certainly candidates for reconstruction. And lastly, I'm sorry, I'm talking too much, Fedor. The last one would be where we're going with valves and how much is that we're going to go to. And Fedor is kind of an expert in flow physiology, et cetera. And maybe you could shed some light on that for us.
Well, that will require another hour.
Absolutely. Can you skinny it?
I think it's one of the most interesting developments in the recent, I would say, 5 to 6 years, and I completely agree with Lowell. It's going to be interesting to see what it will result in terms of how effective it's going to be and whether it's going to be accepted or not. You remember unfortunately, the days of open surgery are not that promising as they were before. But for those of us who did deep vein reconstructions, we all know that the results were quite good. But it's a
But
long
not long term,
operation.
right, Fedor? We don't.
Well,
short term, yeah.
if you look at the results, they're quite good because we're talking about patients with venous ulcers, and we're talking about
Oh, I was
quite
talking about the
amazing
patency.
deep
Yeah,
veins. Yeah.
we can get them to heal for sure.
No,
Yeah.
right, no. No, but what I'm saying, it's a loan operation for which you're not going to pay it, so it's not, doesn't have any future at all. But we'll see what the results of endovascular solution is going to be.
So I think we're really have come a long way in venous disease. We still don't know a lot about it. I mean, well, we do know a lot about it. We don't know all there is. I think we're further along in understanding arterial and indications for that. And I think that we have further to go in venous. And it's going to be exciting for our future generations of physicians because things have completely changed and will change even more.
Yeah, absolutely. And coming back to the trial, the best outcome of this whole development is enormous amount of practitioners who are well educated in venous disease now. I mean, when the trial started, there were a bunch of vascular surgeons, mostly, a couple of what you would call vascular medicine angiologists from Europe, and that's it. The pool of experts, or at least reasonable understanding of venous disease at that time, was quite small. Now you're talking about thousands of people, which definitely should lead to much more in terms of research, discoveries, innovations, you name it.
Do you remember all of the questions, Fedor, about what about the tributaries up in the groin? What are you going to do with those? We ligated first primary division. And then we studied those patients, and what did we find? We found out other issues like neovascularization.
Yeah,
and
right.
then we looked at that from an endovenous point of view, and it was much, 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 much less, like 2.5% versus almost guaranteed.
Oh yeah, yeah. You're so right. And it's another interesting, historical trivia that that the whole idea of ablation below epigastric came from a different reason, because we didn't know how do we know at the beginning of the trial, how do we measure whether the ablation was at that point or not. So we need an anatomical landmark, and that was epigastric vein. It was not really thought at this time that, you know, that's going to be some beneficial or flash, and it was just anatomical landmark. And that all those things came up later.
You know, it's interesting that you mention that, because in my naivety, I went right up to the junction because
Oh, yeah.
that's what we did. We did flush ligation.
Mm-hmm.
And I didn't see any of this thrombus extension. And but I've been reluctant to go back up there, but there are some people that are going to ground zero. But as you know, endothermal heat-induced thrombosis, to me, and our guidelines are played down at these days. Of course, if a patient's high risk, it's different. But where we came from, I mean, we were treating patients. Somebody got, early on got umbrella, filters. Back in those days, I think they were called umbrellas. So it was like, it was it's an interesting history and where we've come from. And, the EVOLVES trial, as Fedor said, was kind of the highlight of where we put all our ideas together. We all of us collectively had experiences and we sat and discussed it. And even ligation, even today, there's people that ligate the junction and do thermal ablation. But there have been studies to submit that that probably is not important. So we've gone a long way, and it's been a great journey.
On that note, I want to thank both of you for highlighting some of the trials, tribulations, and some of the progress that we've made since 20 years since the EVOLVE study. It really was the landmark study that revolutionized endovenous procedures worldwide. So thank you very much for this very interesting, enlightening discussion. I think you really brought to light some of the difficulties, the challenges, and solutions for starting these important trials.
Well, it's a pleasure. Thank you very much, Anil, for putting this up.